Thank you everybody for joining us for the Ultrasound lecture series. But today we're going to continue on and probably wrap up this block with the OB section that we've been working on over the last several weeks. And I'm going to be talking today about how to assess fetal biometrics. We've talked in the last few weeks kind of some of the atypical cases in pregnancy ultrasound and how to do the unique studies with the endocavitary probe and all that. And today we're going to hit a topic that really has some applicability in multiple different spheres of caring for pregnant women, and that's assessing how far along the patient is, right? How close to delivery we are, how advanced this fetus is, because there's a lot of implications clinically that will have for how we're going to, approach and manage patients if we know how far along they are. So with that said, let's dive right on into it and get to our topic today. There we go. All right. So fetal biometrics is the topic at hand today, and what we're going to be discussing over the course of the next little bit. It's probably not going to fill completely an hour, but it'll fill a good portion of that. So the goal, as we think through today's conversation, is we want to teach point-of-care users, whether that be emergency department providers or even other providers who may be bumping shoulders with pregnant women, how to accurately determine the fetal gestational age throughout pregnancy. We were even talking a little bit beforehand. We have one of our illustrious trauma fellows rotating with us right now. It's been a great time to have him here with us. On the first blush, you may say, hey, you know what? Pregnancy ultrasound may not be the most applicable in the setting of trauma and critical care. But then when you got to thinking about it, and actually was thinking about it this out loud, the reality is we see all sorts of patients who injure themselves. And over my career, I've seen a number of pregnant women who've been in car crashes or fallen or been assaulted or various different things. And part of that workup in the trauma bay is assessing for fetal viability, right? To see if the fetus is, alive or if there's some potential injuries there. And then also how far along that pregnancy is, right? Because that's going to really help us determine whether or not we need to assess them, for a longer period of time versus just a quick ED assessment, make sure there's no compelling traumatic injuries and then discharge, right? So this becomes actually rather applicable for anybody, like I said, who rubs shoulders, bumps elbows, whatever metaphor you want to use for patients, with pregnancy. So with that being said, I always like to start off my talks just really thinking through some cases, right? Making up some scenarios in my head that may get me thinking. And actually, this is a strategy I've used from time to time just in my own education and my own practice of, as I'm driving into the hospital, concoct a scenario that freaks me out, right? And start thinking through how I would do that. Or even maybe a scenario that doesn't freak me out, but just I need to examine or figure out how to improve efficiency. And certainly a conversation for future topics or future times. But, it's actually a helpful exercise to make up a scenario and think about it, right? Think step by step, what would I do here? What would I do here? How can I improve this little aspect of the care? And so kind of with that idea in mind, here's a few different scenarios that, frankly, just I made up, right? They're just out of the top of my head, but they're reasonably plausible scenarios of things that you would see in the emergency department. While I can't attach a name and face, to this, there's HIPAA issues. These are very much inspired by patients that I've seen over the course of my practice, right? So patient number one, imagine you're presented with a patient who's a 26-year-old female who says, I've been having some lower abdominal cramping. And today, I noticed there's some vaginal bleeding, right? I was wondering what was happening, why the cramping was happening, and all of a sudden I started spotting and it's starting to pick up a little bit. They took a pregnancy test at home. Probably should know that, right? That's an important thing to do in the differential diagnosis and kind of figure out what's going on. And lo and behold, it's positive. So they say, hey, I'm here. Early pregnancy, spotting, cramping, positive pregnancy test. Man, what do we do now, right? Next scenario is imagine yourself seeing a 35-year-old female, so a little bit older. Age really is probably not the most applicable factor in this scenario, but they say, hey, you know what? I think I'm about 30 weeks, right? That's based on my LMP, based on, my conversations with my OB provider, and when our due date is, I should be about 30 weeks and I don't know, let's say 30 and 3, right? 30 and 3. And I was at home and, I felt something warm and wet. So I don't know, did I wet myself? Did I feel a rush of fluids? I'm going to say it's probably a rush of fluids. what's going on, right? And their vitals are pretty normal, right? So, hey, what do we do in this scenario, right? There's going to be some questions we need to ask and answer as we kind of think through how we're going to manage these, right? And then the third scenario, maybe this gets towards our trauma side. 29-year-old female involved in a high-speed motor vehicle accident. GCS is 9, has a obviously gravid, abdomen. Looks like it's gravid up to the umbilicus. They're hypotensive, bradycardic, kind of approaching hypoxic. This patient is sick, right? What do we do here, right? Because not only do we have one patient, we got the obvious patient, but we have two patients, right? The not so obvious patient. And what we do in the resuscitation for mom certainly has potential impacts for the baby. And the presence of a baby would potentially impact what we do to moms, right? So 3 scenarios that we can kind of imagine ourselves in. Hopefully not the latter, because that sounds pretty serious and terrifying. But 3 potential scenarios that we're going to see in the trauma bays or in the emergency department. And it all gets down to this question, right? Why is knowing the gestational age important, right? Because I think all of them, in all these scenarios, we can say, knowing this is important, and maybe asking the question is kind of the answer, right? It's important to know the gestational age because it really impacts how we're going to approach and how we're going to deal with the patients that we really just presented ourselves. And so as we get started today, we need to ask this question: why is this important, and why do we need to bother learning this information? And hopefully it's a little bit self-evident, but over the course of the rest of the time here today, hopefully it'll become even more self-evident to the point where I've impressed upon you the need to do this as we're evaluating patients, right? So as all good things, we probably should start with a little bit of a definition of terms, right? Most persuasive arguments, right, start with defining the terms. Most conversations start with understanding the basis of what you're talking about so that we can really have a robust conversation about the topic at hand, right? So there's a few terms that we need to define, and those are essentially conceptual age, menstrual age, and gestational age, right? And they seem to be all talking about relatively similar things, but there's some nuances to each of these that really are going to, to differentiate them from each other, right? So conceptual age is basically the amount of time from when conception took place, right, until when the 2 zygotes became, a fertilized ovum, and that fertilized ovum started to multiply and duplicate and become, the embryo, which became the fetus and things like that. So from when that conception took place to present, right, it's a certain time, a certain time frame. And it's not necessarily the most common one used because it definitely certainly requires some knowledge of when conception happens. And since theoretically it can happen anytime in the menstrual cycle after ovulation, there's going to be some variability in the conceptual age. But from a pure, definitional academic perspective, conceptual age is the time since conception, right? Menstrual age is basically an estimate of fetal age based on the number of days, or in certain situations as we get further along, number of weeks since the last menstrual period, right? And so we're starting to get towards definitions that seem to be a little bit more clinically used, if not usable, right? So, hey, when's your last period? Last period was 6 weeks ago. Okay, you're 6 weeks. And this is certainly probably one of the primary ways that obstetricians date and age these pregnancies, right? Now that is to be distinguished from gestational age, which technically is rather similar, but it makes the assumption that the conception happens in the mid portion of the cycle, right? And so it tends to be less of an estimated age and more of a calculated age. And when we talk about ultrasound, this is the term that we're really going to use, right? So technically speaking, gestational age is time since conception plus 14 days. But this is going to be kind of the term that we use, and probably loosen up the definition a little bit as we go throughout the rest of the conversation. But just know that technically there's a slight difference between menstrual age and gestational age. They're very, very similar in terms of how they practically get utilized, right? So it comes down to the point that dating a fetus is really important because it allows us to have basically a reference standard by which we can judge other parameters that kind of happen throughout pregnancy. So, we can judge how far along the baby is, right? When we're expecting to have some delivery, what threshold we need to reach before it's safe to deliver. And then as the baby's growing and developing, is it growing, in all the different spheres of its growth, right? The different organ systems, stuff like that, according to expected parameters relative to its predicted gestational age, right? And then even you can take that one step further and say, hey, look, we are doing things to pregnant women in the emergency department. We're taking care of them. We have come in with various different conditions, and we give them medications. We do procedures, various things like that. And certain medications, particularly, may have impacts on the fetus, right? And it may have variable impacts on the fetus based on its gestational age. And so knowing that may be helpful in terms of knowing which interventions or medications are safe for pregnant women at various different stages. And a classic example I can think of is opiates, right? Generally, opiates are considered to be decently safe in pregnancy, but caution is always advised towards the end of pregnancy. When you have a fetus that's going to come out, you don't want that residual respiratory depression from an opiate-related medication, right at term. And so there's some issues with gestational age that may come into play there. There's going to be various different issues with other medications, through organogenesis up in the first trimester, and then maybe less of an issue kind of in the second or third trimester. So all that to say, knowing the gestational age is really, really important. So the question then becomes, how do we figure that out other than say, well, my last period is, fill in the blank dates? Because the reality is, while a lot of women are relatively in tune with when they have their last period, there's a lot of women who aren't, right? And you say, hey, when was your last period? It's like, I don't know. I really wasn't paying attention, or I noticed it, but I don't know, a couple weeks ago, I really don't write this down and I kind of forget about it, which is certainly not an uncommon thing. And then you can also say, hey, look, there's variability in terms of maybe you're having irregular periods, or you're having some, some implantation bleeding or things like that make obfuscate the whole picture, and just say, hey, I really don't know when the exact last period is. To say that I can definitively date this. And, honestly, I can't be judgmental, right? You could ask me, when's the last time some painful thing happened to me? Like, when is the last time I fell and skinned my knee? I can't remember, right? It's just not something that I hold in my memory bank, and I certainly don't want to equate the two. But I can't be judgmental. Like, honestly, there's better things to do than kind of remember that data in your head. And so if you don't have a tracker or whatever the case may be, it may just not be information that's readily apparently available. And with that said, I should probably move on to kind of what we're talking about for the rest of the time. So there's various different methods of collecting this information of when how far along the baby is. And we're going to divide them up into clinical parameters that estimate gestational age, and then we'll do sonographic or ultrasound parameters where we estimate gestational age, right? So from a clinical methods, we've already talked about it. The easiest, the quickest, the most commonly used is when's the last period, right? And when you talk to an obstetrician on your first OB visit, they'll be like, hey, when's the last time you had a period, right? And you find the first day of the last period, and that is when the clock starts for the initial estimation of gestational age. So you say, hey, I took a positive pregnancy test. My first day of my last period was 6 weeks and 4 days ago. Well, you're 6 and 4, right? That's your gestational age. And then we can extrapolate from there. I think it was 200, obstetricians can correct me if I'm wrong. I think it's like 218 days from the first day of the last period to when your estimated due date is. Don't quote me on that date. Maybe 282. It's in the 200 somethings range. And that can give us our estimated due date, or EDD, for this pregnancy. But as we kind of alluded to, this is a rather imprecise science, right? For a number of reasons. I mean, certain women are clockwork, right? Certain women aren't, right? So if you have irregular periods, this is going to be a challenging thing to really identify when the first day of your last period is. The other thing is just patient recollection. We talked about this a little bit. Recollection bias, like, you may not remember, right? It may just be so part of the normal thing that you just don't pay attention to the fact that it was this day and this time. And then, like I mentioned before, mistaken implantation bleeding. So maybe you had a period, maybe you implanted, you had a little bit of a subchorionic hemorrhage that let loose, and then you thought it was a light period, and now, the reality is your last period was 2 periods ago. So there's a lot of variability in terms of recalling which is the exact one, which makes this an imprecise science. there's things coming out right now that would, suggest that we could use like basal body temperature to maybe get at when ovulation happens and start kind of getting a little bit more precision or scientific precision in this. I know the latest iteration of the Apple Watch series has basal body measurements and can predict ovulation. And so there's a little bit more scientific ways of doing this, but again, it all comes down to recollection of when that last period was. And so that's method number one, right? I think we've kind of regarded why that's probably easy but imprecise. Method number two really is not any better. In fact, it probably fares worse, and that is fetal movement. And this is more of a historical relic than anything that's actively utilized right now to estimate gestational age. But certainly before the advent of ultrasound, for sure, and before the advent of pregnancy tests and home pregnancy tests, the way you may diagnose it is a number of clinical factors. I don't feel so good. I don't have periods anymore, and there's this thing that's kind of fluttering around inside of me, right? And that may be the way that it was diagnosed 100 years ago, right? It's certainly written about. It's certainly mentioned as a way of measuring gestational age. But it's, as you can imagine, it's so imprecise, right? And the reality is the idea of fetal movement, feeling that fetal movement, or the term quickening as it's been referred to in the past, generally happens about age 16 weeks, right? Or when pregnancy is about 16 weeks along. And so you can say, I felt things kick. I must be around that, just barely into my second trimester, excuse me. But this is highly variable, right? And so the idea of quickening or fetal movement has been reported to exist or to begin somewhere in the 17 to even all the way up to 21 weeks, right? So you're halfway through your pregnancy before you feel it. And so, as you can imagine, it's very, very imprecise. And, this can be due to a number of factors. And in my own family, right, my wife and I's experience, we've had a number of pregnancies, and the whole notion of feeling your baby, while it does happen, right, happens at slightly different times and in slightly different ways. In our experience, right, it's been related to, number one, is the kid more active? I mean, I've certainly had kids that are more active in utero than others, right? Number two, have you had previous children before? The first one's harder to feel because you don't really know what you're feeling for. And the second, subsequent ones is like, I remember that. At least that's what I've been told. And number three is placental location plays a huge impact, right? In our experience, we've had a number of placentas that have implanted anteriorly in the uterus, and that almost serves as a little bit of a cushion that makes it harder for you then to feel that movement because it's just kind of an extra degree of thickening of that uterine wall, whereas fetuses, or not fetuses, but placentas that implant either more posteriorly or somewhere other than the anterior wall, it may be easier to feel those earlier just because that movement is transmitted through the uterine wall a little bit more easily. And so a lot of factors that come into play that make this one highly variable. So we'll move on from that. Then the third one is just uterine size, right? And this one, I remember back in my OB rotation, in medical school, that it's kind of a quick and dirty way of figuring out roughly how far along they are. Remember, you take the tape measure, put on the pubic symphysis measure to the top of the fundus, and whatever that centimeter mark roughly corresponds with certain, gestational ages. And then you say kind of, once you hit out of the first trimester, they start coming out of the pelvis. Once they hit that umbilicus, you're probably about 20 some odd weeks along. And once you hit the xiphoid, you're getting really close to being like mid to late 30s, right? And so there are generalities to kind of how you age these babies. But again, they can be imprecise, right? For a number of reasons, whether it be, the baby maybe has a I'm blanking on the term right now, but the fetal lie is horizontal in its orientation versus vertical in its orientation. The size of the fetus, the number of babies, if you have multiple pregnancies, in that, or if you have like twin gestations or things like that, all can adjust kind of the height essentially that would go into the uterine sizing estimation. So again, all these methods they exist. They can give you some utility in the moment. They can be kind of a quick and easy reference, but certainly are less than precise when it comes to making major decisions in terms of what we're going to do for this patient or when we could expect delivery, right? So that's going to really bring us to the bulk of today's lecture, the remainder of today's lecture, and that's really assessing the ultrasound methods of measuring gestational age, right? So we can get a really good, accurate understanding of how far along this pregnancy is, right? And from this perspective, I think if we divide it up in two broad categories, it's helpful, right? Number one is the first trimester, right? This is the major trimester that's really applicable to the emergency department. Second and third trimester as well, certainly not unimportant. They are less applicable to our practice as emergency providers, but still have, we'll still see these patients. But if we divide up into this first trimester and then second and third trimester, kind of as a lump sum there, it kind of gives us a helpful benchmark to look at it, right? And so really there's a number of ways of getting at this gestational age question in the first trimester, right? In the first one, we've kind of talked about this already. If you remember back from a couple lectures ago, or if you're watching this on YouTube, if you scroll back a couple videos ago, and we talked about ways of measuring, fetal loss and things like that. Those lectures, we talked about a little bit of the normal early progression of pregnancy, right? Because that has impacts in terms of what metrics we use to describe viability of a pregnancy. But if we go back to this notion of in early pregnancy, there are particular sonographic findings that are decently consistent, from pregnancy to pregnancy. In fact, they're really consistent. And so you think about it, in that 5.5, 6 week mark, there's a lot going on sonographically that, is pretty consistent from pregnancy to pregnancy, right? So generally, at about week 5, you start seeing the developmental formation of a gestational sac, right? That sac with inside the uterus that, indicates that this is where the pregnancy is going to happen, right? Really, in my experience and according to the literature, this generally happens around 5 weeks, right? Generally, you don't see it earlier than that, and generally you see more than that, farther along, right? And the other thing you'll notice, particularly in the image on the left-hand side of the screen, is what's called the double decidual sign, right? And so the two different layers of the decidua, essentially, as they form and kind of develop for this pregnancy rate. And that is really highly predictive of pregnancy. In fact, there's been articles that have been published saying, hey, this double decidual sign is really positively correlated with pregnancy, to the point that if you see that, you can be reasonably assured you have an intra-uterine pregnancy. Now, for me, in my understanding of the literature and general practice in the emergency department, I don't consider a double decidual sign to be dispositively convincing that this is a pregnancy, right? It is highly suggestive, and if you see that, you're less likely to be encountering other things. But I wait until the next step, and that's 5.5 weeks, to see the yolk sac to say definitively, without a shadow of a doubt, this is an intrauterine pregnancy, right? And so that leads us on to the 5.5 week mark, which is that middle image, and you see the small little ring-like structure inside that gestational sac. And when you see that, right, that is the yolk sac, right? And that is generally seen at about 5.5 weeks, across pregnancies. And so if you see that, you can say, yeah, I'm generally about 5.5 weeks. And if you don't see anything else, then you can say I'm pretty decently sure you're in that age range, right? And then finally, the fetal pole begins to develop around 6 weeks, right? Again, in my experience, maybe I've seen a few earlier than that. Definitely you see them later than that. Around 6 weeks is kind of where they all start to kind of cluster, as to when you start seeing the fetal pole, right? So 5.5, or 5.5, 6 weeks, the normal progression in early first trimester, is a really, really helpful metric to say kind of approximately where you are in the pregnancy, right? Now, moving from there, there's a couple other things that we can do to actually put measurements on structures to get some numbers, right? And the first one is a mean sac diameter, right? And so the theory behind this is that the gestational sac grows kind of at a predictable rate in the early first trimester, right? And, it starts small, and it gets bigger and bigger and bigger, and eventually becomes, large. And that happens predictably over the course of that early time in pregnancy, right? And so therefore, the thought is you can measure that size, right? And from there, calculate a gestational age. And you can look up in textbooks, there are charts that say gestational sac, mean sac diameter essentially of this millimeters corresponds with this many, days essentially, or weeks, days of gestational age, right? And in our machines, you don't have to look it up on a chart. You just take your measurements and it spits out a number. It does the calculation for you. And this is generally what's done early in pregnancy before you visualize the fetal pole, right? So once you see baby, kind of the ship has sailed on this one. You don't really need to do this one. You just measure the baby. But before you see the baby, this is kind of what you do to measure, to provide a measurement, get a rough estimate. So you're going to be doing this a lot in the early, like 5 to 6 week range, to make sure you to get your numbers in your early pregnancy. How do you do it? Right? You find the gestational sac. You scan it in 2 orthogonal planes, so in a sagittal orientation and a transverse orientation. Or if you're doing transvaginal, you do it in the sagittal and the coronal view. And then you measure the 3 cardinal directions, very much like we would do a bladder volume, right? You measure the up and down, the AP, and the side-to-side measurements, and the machine calculates that mean sac diameter, right? So it's not a volume; it's a mean sac diameter, and then plugs that into the reference, and spits out a gestational age, right? So that's mean sac diameter. A couple of considerations for this one, like I said, it's generally performed early in the first trimester. In fact, as it gets larger, right, as that mean sac diameter grows to be beyond about 8.5 centimeters, the accuracy really begins to fall off. Now, interestingly enough, 8.5 centimeters is pretty far along. You're looking at about 14 weeks of pregnancy, right? So I really have never measured one of these at 14 weeks. So I think your utility of it is going to fall off before your accuracy does. But you can't really do this to like a 30-weeker and expect to get some accurate results, right? And really, it's not recommended for estimating due dates, right? This is kind of it helps us in the ED, gets us kind of puts us on the map, as it were, in terms of how far along we are. But OBs are not going to use this as a metric to say, okay, we're going to adjust our estimated dates, right? We're going to keep the dates, the clinical dates measurement, and this is helpful, corroborating information, but it's not going to be a major mover and shaker in terms of our gestational age estimation long term, right? So that's a couple important things to remember that one. That leads us to the next metric, and this is probably one of the more important ones in the whole talk, and that is our crown rump length, right? And we do this all the time, right? All of our first trimester studies, we do a crown rump length, or at least all of them we should, at least if it's the first pregnancy scan that the patient's had, to estimate how far along that patient is, right? And so the same idea applies to this metric as to the mean sac diameter. The baby starts small, they grow, and they grow at a relatively predictable rate, at least at this stage in pregnancy. And so just like we would measure a mean sac diameter to get its gestational age assessment, you can measure the length of the fetus, right, from the top of the crown to basically its rear end, excluding arms and legs, and that measurement can correlate with a gestational age, right? There's a calculator you can plug it into on the machine. You can also look up in the textbooks what each millimeter by millimeter measurement is going to correlate with in terms of gestational age. Right, and the key is you want to find the fetus in the longest dimension possible, right? So you're going to have to do a little bit of probe manipulation to scan that fetus. And it doesn't have to be in sagittal, doesn't have to be in transverse, whatever orientation the fetus is in, that's in the longest dimension, right? That does not include the arms and the legs, and very importantly, does not include the yolk sac, right? And this is really important kind of early in pregnancy where the yolk sac and fetal pole are very, very close to one another. But you find that longest dimension, you measure from the top of the crown to the bottom of its rear, and that's going to be your crown rump length. And technically speaking, OB is going to want to take the number that they're going to use, the average of 3 numbers. Now, do we do 3 all the time? No, but if you watch them over, in the OB lab scanning an early first trimester, they're going to do it a number of times and then average those out, and that's going to be the number that they utilize, right? So a couple important considerations. In this capacity, it's the most accurate gestational age measurement, period, right? And this is coming from ACOG. OBs want to know this number, right? Early on in pregnancy, the earlier the better, right? But early in pregnancy, it is the most accurate gestational age measurement there is, right? To the point that if there is a discrepancy between ultrasound measurements and LMP-based measurements, if that discrepancy is greater than 7 days, generally OBs will defer to the ultrasound dating over the LMP dating. If they're consistent, then they may just keep the LMP dating. But that's what they want to know early on in pregnancy is crown rump length, because it's really accurate down to about 5 to 7 days. So this is what I tell patients: hey, you're about 6 weeks, 3 days, plus or minus about a week, right? You could be 5 and 3, you could be 7 and 3, but you're really close in that capacity to how far along you are, right? Obviously, accuracy is better early in pregnancy. So as we get later and later in the first trimester, accuracy is going to fall off. And the reason for that is as we get further and further along, the fetus is able to bend and move in various different ways. And you can imagine if it bends its head down versus kind of flexes its head back, it may impact the measured length or distance to the point that it may throw the calculation off a couple days, right? And so once you really hit that 12 week mark, accuracy starts falling off, and I'm starting to look for other methods. That being said, I still do scan, some of these older ones with the crown lump just to get it right, to have that number. So that's the first trimester, right? Let's move on to the second and third trimester because there's some helpful metrics in here that we can utilize to scan these pregnant women in terms of getting their gestational age, right? But before we really get into the metrics, we need to talk a little bit about some neuroanatomy, right? And so I pulled some images from the internet last night that kind of help understand some of the anatomy, some of the fetal anatomy that we need to identify as we're scanning these patients, right? So this is the axillary transverse view of the fetal calvarium, essentially, sometime during the course of pregnancy. Obviously, it's a little bit further developed than first trimester, obviously, but this is kind of what you're going to see. And this is the level we want to look for, right? We don't want high up in the brain. We don't want way down low. We want right in this area where we can see the paired thalami, right? So you can see the asterisk represents each different side of the thalamus, right? And then you can see the arrow there on the right points to the anterior falx, right? And then the very important structure, that V-shaped caret, the upside down caret and the right side up caret, is pointing to what's called the cavum septi pellucidum, all right? Septi pellucidum, which basically, I had to look this one up. It's a term I've thrown around for a while, but I had to really look it up and just kind of remind myself exactly what we're talking about. The cavum septi pellucidum represents a space between the septum pellucidum, right? There's a paired septum pellucidum, and this is a unique anatomic structure in the fetal brain, right? It's present in about 100%, in all fetuses, and it disappears, right, around between 3 and 6 months of post-birth age in the vast majority of people, in about 85% of people, right? And so it's a space between the lateral ventricles, right, that connects the corpus callosum, right, to the fornix and the anterior commissure of the fetal brain, right? And so you can see that in kind of that midline area in the image that's represented here, you can see the corpus callosum is that upper U-shaped connection or neural connections there, and then the anterior commissure is the lower upside down U-shaped neural connections that cross midline. You can see those septum in the middle, and the very, very thin ones kind of at the upper portion of that is the septum pellucidum, right? And it forms this small little fluid-filled space kind of between the two that can actually be seen and measured, right? And so here's an example where you can see the septi on either side in that cavum septi pellucidum. So like the cave between the septi, essentially is how I remember it, is that small little fluid-filled structure just anterior to the thalamus right there. And really, and the way I've always looked for it is you look for the arrow sign, right? So if you can think about it, if you kind of imagine a little arrow, and you don't have to imagine, I'm just going to put it right there for you. The posterior aspect of the thalamus plus the midline equals kind of like this arrow that points to their posterior portion of the head. And so if you are in the area where you see that little cavum septum pellucidum, the thalamus, kind of that arrow sign, you're in the right spot, right? The right level to make this measurement for the fetal biometrics. And you really want to avoid including the cerebellum in there. You want to get just kind of these structures, kind of the triangulation or the of these different structures, right? So with that anatomy in mind, let's look at the first method of measurement of just measuring gestational age, and that's the biparietal diameter, right? And this is probably one of the ones that I use most commonly because you find the head, you find the exact area, right? The transaxial orientation through the thalamus and the cavum septum pellucidum, and you measure the biparietal diameter. So this is basically in the axial section of the fetal brain, at the level of the thalamus and the cavum septum pellucidum. You measure the transverse diameter from the outer table of the calvarium that's nearest to the probe to the inner table of the calvarium that's farthest from the probe, right? And that transverse diameter correlates with gestational age. And again, you can look it up in tables, but the machines have a calculator in terms of spitting out a gestational age for the pregnancy. So in this example, you can see that it is approximately 5 centimeters, right? And it correlates with a gestational age of 22 weeks. And while I don't advocate that you memorize every dimension, it's helpful to kind of have a rough estimate of what expected dimensions would be, right? And so as we kind of approach our third trimester, right, thinking about 5 centimeters is kind of a reasonable number. And so, as you scan these, just kind of keep in mind what the numbers are, so you can have a rough estimate. When you look at one, you say, oh, you can just kind of get a rough idea when you glance at the patient, right? So a couple important considerations: variability increases with gestational age, with advancing gestational age. I mean, we've seen this to be the case in every other metric that we measure. It's most accurate earlier on, and it becomes less accurate as pregnancies develop, right? And the reason for that is, early things are pretty consistent. We know just looking around this world that not everyone is 6 foot, 175 pounds, right? You can imagine some average height weight combination. I just made that up in my head, but you can imagine some average, but everyone's gonna be some variation on the theme, right? And so we would expect, since we see that variability in the world, we also would expect to see it in utero as we're approaching kind of becoming members of this world, right? And it probably becomes even more obvious when you say, look, there's some babies that are born at 6 pounds, some babies that are born at 10 pounds, right? And so you're gonna expect to see a size variability later on in pregnancy, right? So expect that to become more variable as the baby gets older. Number 2, the cerebral hemispheres need to be symmetric, right? If you're off axis, right, off that transaxial orientation, you're going to have an abnormal measurement, right? So you really have to have equal amount of cerebral hemisphere on either side of the midline for this to be accurate. And number 3, the important thing is, which is going to differentiate this one from the next one, is there is no count for variation of head shape, right? And so this is very much reliant on the transverse diameter of a head, but it has no account for the AP diameter of a head, right? And we know that people have various different, head shape morphologies. Some people tend to be more round, some people tend to be more oblong, and maybe you have the same diameter and one's shorter, one's longer in the AP to orientation. It's not going to account for that, right? So it's an important consideration when we think about the biparietal diameter. And so to overcome that, the next option that we have is doing a head circumference, right? And so this is basically at the same location, right? That paired thalamus, the arrow sign, the cavum septum pellucidum. You can see all of those in this, this head that we see on the screen here. It's basically, instead of measuring, from one temporal side to the other temporal side, you're measuring the entire perimeter around the head, right? So it's the exterior perimeter of the calvarium, kind of at the same level that we were at for biparietal diameter, right? And so the machine gives you a little oval that you can overlay on the head. You can adjust its width, you can adjust its length, and kind of the roundness of it, and overlay that on, and it will calculate that perimeter, right? In this situation, it's about 21 centimeters, and again, it roughly correlates with that 22-week pregnancy that we saw in the last patient. And so this one's really helpful, right? This is another way of getting a gestational age assessment. And some important considerations on this one is that, again, like the previous one, the variability increases with advancing gestational age, right? And so the further along we get, the less accurate this may be. And it's still going to give us a rough correlate, but it may be less and less accurate. So if you're going to make major decisions on it, earlier is better, right? But according to the sources that I was reading, this one's actually probably a little bit more reliable than the biparietal diameter because it accounts for that AP orientation or the AP length, not just the transverse width of the head, right? And so it accounts for more of that variation in morphology in terms of head shapes. Now, to add to that, one study that I read basically indicated that a combination, they came up with a mathematical formula between the biparietal diameter and the femur length, which we'll talk about next, was probably the most accurate way of assessing, second and third trimester gestational age. Now, I don't routinely calculate that out, but just know that this is probably a little bit more accurate than biparietal diameter, and is something that you can use. And certainly in our practice, what I've done is done both, right, and see if they both roughly correlate with one another, and that's really, really helpful, right? And that leads us to our third and final method of assessing second and third trimester gestational age, and that's the femur length. And this one, it kind of goes without saying, just because it is self-evident that you measure the length of the femur. Although I've certainly seen it, seen this messed up in a number of different ways over the years. And so the idea is you just find the femur, right? Find the full length of that femur and measure it from essentially the femoral head down to the femoral condyle on the other end. And you'll know you're at the full length because you see the femoral head and the femoral condyle tend to be a little bit thicker than the mid-shaft diaphysis of the femur, right? And you'll kind of see that little thinning out in the middle and then kind of thicken back up at the ends. And so you want to measure that full length of that femur, being careful that you've oriented your probe in such a manner that you actually have found the entire full length of it and not foreshortening it. And this is really the major pitfall, is you can foreshorten that femur and not realize it. So you want to kind of very carefully manipulate that probe to make sure you're on the full length of the femur and measure it. And also you want to make sure you exclude the epiphysis of the femur. You can see that little ossification kind of the femoral head. You really want just kind of that diaphysis of the femur, right? But if you measure that, if you take that measurement, again, the machine will spit out some numbers and give you a calculation of the gestational age based on that measurement. Again, some important considerations here. It tends to be reliable after about 14 weeks, right? I didn't find anything that definitively said that reliability falls off, later on in pregnancy. But to me, it makes sense that the accuracy is going to fall off kind of as we get further and further advanced in the pregnancy, just because we know that some people have longer legs and some people have shorter legs, and there's going to be more variability as we get towards the end of pregnancy. But generally, at the end of the first trimester, into the early parts of the second trimester, this tends to be a decently accurate measurement metric. And like I said, with that one study I mentioned before, combined with the head circumference, tends to be a very accurate way of estimating gestational age. But you need to be careful you identify the full length of the femur, and even just the femur itself, right? There's multiple long bones that are developing inside that fetus. And I've seen, on occasion, that the humerus gets measured inadvertently in place of the femur. And so you really want to be careful that you are accurately identifying the femur and not some other long bone, so you can get that accurate assessment for the femur length. So with that said, that kind of is the extent of the fetal biometric methods that we're going to talk about today. There's certainly more. You can measure abdominal circumference. You can measure, there's even a humeral length that you can measure. I think we probably have, with these three, have reached the law of diminishing returns, because I think these are probably going to be the best, fastest ones that we can do. And when you start getting into these other metrics, you're really correlating with all of them to kind of get a general rough estimate of how this baby is doing in all of the different measurements. And so I think if we keep these in mind, these different ones in mind, these are probably going to be the most helpful for us in the emergency department. So just as a brief recap, there's really three things I want you to take home from today's talk, right? So three take-home points to remember. Number one, gestational age dating is really, really important, right? It's, we may not think about it, all the time and routinely, but knowing how far along a pregnancy is really important. I would say it's probably similar to knowing the age of your patient, right? You're going to manage a patient very differently if they're in their 30s than if they're in their 60s, right? And so having that understanding is critically important. Number two, methods of dating become more variable with increasing gestational age, right? So your best bet is to get that early first trimester crown rump length. To the extent that you're not there or didn't get that or can't get that, the earlier you get something, the better, right? And there's different methods of collecting that gestational age assessment, but earlier is always better, right? And number three, more of a big picture, concept is ED physicians should be familiar with various different methods and limitations for measuring gestational age. And I probably even broaden that out, given our introduction, that physicians who interact with pregnant women who do bedside ultrasound, not just ED physicians, should really be familiar with this, because this is basically bread and butter OBGYN outside of the OB office, right? So with that being said, I'm going to open things up for questions. If anybody has any questions, comments, concerns, things they want to chime in, talk about, feel free.